Hello, everyone. Welcome to today's class. Today's presentation is about machine learning in pharmacoepidemiology. My name is Yinan I'm currently assistant professor of pharmacy administration in the School of Pharmacy. My research primarily involves using large-scale secondary data to evaluate the effects of pharmaceuticals in a different types of the health outcomes. And I also have a special interest in using machine learning to advance prediction analytics based on analysis of large data. Today's topic is application of machine learning in pharmacoepidemiology. Before we dive into specific research projects, I will spend some time for us to review the discipline pharmacoepidemiology and real-world research, and then in the following time, I will talk about different machine learning projects in the field of pharmacoepidemiology. And lastly, I would like to invite you to contribute your thoughts in the field of using machine learning in the real-world research as a future pharmacist. You may have already learned in your social administrative pharmacy class, the pharmacoepidemiology is the study that is the research that involves application of epidemiological methods to study the utilization of medications as well as the impacts of medications on the effectiveness outcome, safety outcome, or the cost outcome. There are many examples in the realms of pharmacoepidemiology. It can be understand the adverse drug events among rheumatoid arthritis patients. It can also be using real-world electronic medical records data to understand the effectiveness between the direct oral anticoagulants versus warfarins in atrophy fibrillation patients. It can also be using the claims insurance, commercial insurance claims data to understand the healthcare resource utilization and cost among dementia patients. Pharmacoepidemiology findings helps to complement the traditional real randomized clinical trial data because pharmacoepidemiology research use the data collected among the patients who are seen in the real world settings. It can be probably the older patients, pregnant women, or the pediatric population who are usually excluded from the clinical trials. We can also study the effects of drug-drug interaction or the among those with different comorbidities. The growth of pharmacoepidemiology comes under the regulatory law in 2016. The Century Cures Act, signed in 2016, allows FDA to use the real-world data or real-world evidence to support regulatory decision-making. Pharmacoepidemiologist uses the real-world data to perform different types of studies. Real-world data there are different types of real-world data. It can be physician notes, it can be commercial insurance claims, or it can be patient registry. And it can also be some unstructured data, such as data collected from wearables, sensors, or even social media. As mentioned, the real-world evidence generated from various types of real-world data complements the clinical trial findings because in the real world data, we can capture healthcare information from a very broader, diverse populations of different ages, maybe the pediatrics or the pregnant women, those patients who are usually excluded from clinical trials. We can address the research questions that cannot be studied because of ethical feasibility reasons from the clinical trials. We can also use in pharmacoepidemiological research to study some rare adverse events, which usually requires very large number of patients and longer follow-up. And it will be very expensive to study, or sometimes impossible to study such real adverse events using the clinical trial data. Now, with some understanding of pharmacoepidemiology study and real-world data sources, I would like to shift the gear to talk about several research projects that I have been involved in. And these research projects are all related to using machine learning pharmacoepidemiology or real-world research. I will start with two systematic review projects to provide you some foundations about the use of machine learning in the real world research. And then I will move to two database projects involving application machine learning on real world research. Well, you may already learned from Dr. Lee's class that when we talk about machine learning, it involves, it can be generally categorized as a supervised learning or unsupervised learning. For the supervised learning, we know that it refers to unlabeled data. There is usually a multiple, a variety features we can use to predict a labeled outcome. Whereas in comparison, in unsupervised learning, it involves the unlabeled data, and we use unsupervised learning to identify the patterns underlying the complex data. In the following sections, I would primarily focus on the use of unsupervised machine learning. The first project I would like to share is titled Application Machine Learning Predicting Hospital Readmission among the US literature. This is a scoping review. The motivation for us to do this project is under the ACA, there is a hospital readmission reduction program. This is a Medicare value-based program that incentivizes hospital to reduce the hospital readmission outcomes and through improving care coordination. And this program supports the national goal of improving healthcare for Americans by linking payment to the quality of hospital care. In this project, we synthesize all the US literature that involving machine learning applications in predicting hospital readmission. We reviewed electronic databases, including PubMed, MedLive, and Embase. Only observational study leveraging machine learning techniques for hospital readmission were included. The key takeaway for this study is after reviewing among 522 citations, 43 studies met the inclusion criteria. Regarding the topics of application machine learning for hospital readmission, Majority of the studies utilize the electronic health records, or we can EMR, EHR, followed by the population-based data sources, and they are around 10% use administrative insurance claims data. The common machine learning for the binary outcome prediction of hospital readmission were decision tree-based algorithm, followed by the neural networks and the regularized logistic regression and support vector machines. The next systematic review project is titled Application of Machine Learning Prediction Survival Outcomes using real-world data. As you can see that in the prior project, we look at the hospital readmission as the binary outcome. In this project, we focus on the survival outcome, or we can call it time to event outcomes. What is the survival outcomes? Survival outcomes are usually, we call it time to event outcomes. It is started in the cancer patients. In cancer patients, oncologists care about time to survival or progression disease-free outcomes. This is continuous outcomes starting from the index date until key clinical outcomes. So it's time to event outcome. It can be a survival, such as what we can call it time until death, or time until disease relapse, time until hospital discharge. The motivation of this systematic review is because there is a growing interest, especially in oncology, to evaluate time to event or survival outcomes. We reviewed the application machine learning for survival analysis using real-world databases in PubMed and Embase. Up to 28 publications were included, and the major source of real-world data were administrative insurance claims data, followed by the EHR data, and then a few use patient registry data. There are also many non-US studies from Europe or England or China or India. The main machine learning algorithms to analyze the time to event data were random survival forest, followed by neural networks. And the time to event outcomes, including these studies, were either the disease prognosis or clinical events. Among the cancer patients, there are also very few use the treatment outcomes. Now, I want to spend more time to talk in depth about two database projects involving application machine learning in real-world data. The first project is internally funded project by the Institute of Data Science at University of Mississippi. In this project, we developed interval machine learning models to examine the treatment switching among patients with multiple sclerosis. This is a study analyzing EMR data. You may check the link if you want to download the study or take a more closer look. Well, the motivation to do this study is that while there are some application of machine learning in different neurological conditions, application of machine learning in the multiple sclerosis disease were often limited to predicting the disease prognosis of multiple sclerosis or the disease subtypes of multiple sclerosis. There is limited application of machine learning in predicting the treatment-related outcomes such as disease-modifying agent switching among multiple sclerosis patients. So in this study, we analyzed 2019 China Tech's EMR data to identify US patients with multiple sclerosis diagnosis. We leveraged several machine learning prediction models, such as Lasso, list absolute shrinkage selection operator regression, or the random forest, and also the extreme gradient boosting method. Many of you may already know that both the random forest and XtraBoost were are considered the ensemble machine learning method. Both these two models is creating a list of decision trees to predict the outcomes, and these two both of them are tree-based method, whereas the Lasso is regularized logistic regression method. Well, it involves penalties in the traditional logistic regression method by penalized some of the coefficients of the parameters into zero. That's to obtain a parsimonious set of coefficients. All these machine learning models were trained by 72 baseline factors using 70% of randomly split data. And then the tenfold cross-validation is used to help us to select the best model parameters. Different models have different hyperparameters as listed here. And then the remaining 30% of data were used to validate this machine learning method. And we use the area under the curve AUC to evaluate the machine learning performance. We also use the accuracy recall F1 score to evaluate this machine learning performance. I would like to share you some results here. As you can see that in this study, we obtained 7,258 patients with multiple sclerosis who were also prescribed at least one disease-modifying agents. During this 2 years of follow-up, 60% of patients with multiple sclerosis had a switching outcomes. And as you can observe from this table, this model performance of these machine learning models varied as compared to the random forest as the reference model. As compared to the logistic regression as the reference model, the random forest has significant improved model performance. And then both the Lasso and XtraBoost had a similar performance. We also identified important predictors from these models. As we can see, there are some overlap in terms of the top important predictors across these models. But also both the random forest and XtraBoost have identified some unique key predictors as compared to the Lasso model. Overall, we can see that the random forest developed in this study provide better prediction for treatment switching in multiple sclerosis as compared to logistic regression based on the matrix of AUC. The most important predictors identified in the random forest for treatment switching, such as age, type of indexed disease-modifying agent, and the time period of indexed disease-modifying agent may help the clinicians, rheumatologists to identify the interventions to optimize the treatment selection strategies, and at the same time with the goal to improve the health outcomes with MS patients. We do acknowledge that future research are needed to understand the roles of machine learning techniques in predicting treatment outcomes for a shared decision makings with a goal to optimize the treatment outcomes. Now, the next study I want to talk about is the using machine learning to predict an adverse event, that is the venous thrombotic events for older adults with rheumatoid arthritis. This study is a collaboration with my colleagues at my department, including the department chair and also rheumatologist, as well as a data scientist from Houston area. The study is still under review by exploratory research in clinical social pharmacy. The motivation of the study is that if you are somewhat interested in rheumatology disease like me, you will notice that FDA has issued a black box warning on the venous thrombotic events and other safety events related to the newly approved class of therapies, that is the orally taking Chinese kinase inhibitors in the patients with rheumatoid arthritis and other inflammatory arthritis disease, because the oral surveillance trial, which has been published in New England Journal of Medicine, has shown that they are observed higher risk of major adverse cardiovascular events and malignancy associated with this JAK kinase inhibitor as compared to the standard of care TNF inhibitors for a group of patients with rheumatoid arthritis who have a higher underlying CV risk. Under this regulatory warning, we aim to leverage a novel machine learning algorithm to predict venous thrombotic events in older adults with rheumatoid arthritis after they started the treatment with biologics or targeted disease-modifying anti-rheumatic drugs. And at the same time, we also want to compare the random survival forest model with the traditional Cox regression model in terms of the predictive task. In this study, we analyzed the most recent, almost 10 years of Medicare administrative insurance claims data, focusing on U.S. older adults who have at least one diagnosis with rheumatoid arthritis, as well as initiating these targeted disease-modifying anti-rheumatic drugs. As we mentioned, we leveraged the 2012 to 2020 Medicare claims data. The Medicare claims data represents a national representative Medicare fee-for-service public insurance beneficiaries. Majority were older adults. There were some of them who have end-stage renal disease or disability. But in our study, we only focus on those who are older than 65 years or above. In the Medicare claims data, it involves the identified insurance claims from a variety of sources, can be inpatient, outpatient, or pharmacy claims from the outpatient prescription pharmacy claims data, in addition to their demographics. In this study, we focused on several groups of medication exposure, including TNF inhibitors, non-TNF biologics, or targeted disease-modifying anti-rheumatic drugs. The outcomes of venous thrombotic events were identified using the Medicare medical claims data using ICD diagnosis code. It is operationalized as a composite of events involving both the pulmonary embolism or deep vein thrombosis. And we use previously published papers to help us to identify this ICD diagnosis code. Now, I want to spend a little time to talk about this machine learning algorithm that we use. As we mentioned, we use the random survival forest. You may notice from the part one where we talk about the terminologies for machine learning for binary outcome, terminology of machine learning for survival outcome. The random survival forest is just an extension of tree-based ensemble learner method, but it can be adapted to prediction of time to event outcome. It is able to handle large high-dimensional data sets, as it is able to automatically handle feature interaction and is robust to outliers. As I mentioned from the prior slides, from our previous review, RSF was one of the most popular machine learning algorithm for the time to event outcome based on the real world studies. To build the RSF model, we identified 63 baseline factors, including a list of demographics, a list of clinical characteristics based on the claims data, either is medical claims, prescription drug claims, or outpatient procedure claims. First of the data was split into 70% for the model development and remaining 25% for model evaluation. And in the model development process, we also use the 5-fold cross-validation to help us select the best model parameters for this RSF model. For the evaluation of model performance, we included Harrow's Concordance Index, C-index, as well as the AUC and Braille score. The C-index is defined as concordance pairs divided by all the permissible pairs. The Braille score, it's a commonly used evaluation matrix for the models predicting time to event outcomes. It helps us to compare the predicted survival probabilities with actual outcomes. And this RSF also have the VIM procedure that can help us to predict, to identify the top features. Now, I would like to share the results. The study sample included 3,648 individuals with rheumatoid arthritis. Majority were TNF initiators, followed by the non-TNF initiators, and a few used the TS DMARDs or the JAK inhibitors. Most of them were female, white, from the South. But this data were randomly split into the training set for the model development and testing set for model evaluation. As you can see here, the random survival forest model achieved a C-index of around 60%. The regularized Cox model was a little bit inferior to the RSF model with a C-index of around below 60%. And we can also see the RSF model had reached integrated Braille score of around 0.1516. You can see this demonstration, the Braille score, over the time from examination of the testing data for the random survival forest model. And this RSF model also gives us a list of important features. Apologize for this busy picture here. I only highlighted the top 12 influential variables with highest importance scores. In predicting the venous thrombotic risk for the rheumatoid arthritis patients, based on the results of the RSF model, the top features include a number of emergency department visit, number of inpatient visit, Alex-Sousa scores, number of outpatient visit, frailty score, age, number of recent inpatient visit, and various cause vein surgery, estrogen exposure, and claims-based rheumatoid arthritis severity index, and coagulant use. It is interesting to note that these top features includes both the rheumatoid arthritis specific variables, such as the number 11 claim-based RA severity index. It also included non-RA specific variables such as Alex-Sousa scores, number of outpatient visits, and frailty score and age. What is the main takeaway here? Of course, this is just exploratory analysis as far as we are concerned. This is the first attempt to leverage a novel mode of renal survival forest machine learning in the field of older adults with rheumatoid arthritis receiving these biologic target synthetic DMARDs in predicting an important safety outcome, venous thrombotic events risk. And we can observe that as compared to the regularized Cox model, this renal survival forest had modulously improved prediction performance. Because the RSF can help us to identify a list of important variables, the findings helps to inform the stakeholders, such as clinicians, as to personalize monitoring strategies to manage the adverse VT risk in older adults with rheumatoid arthritis. The study also provide that they observe comparable safety across the BOTS DMARDs among older adults with rheumatoid arthritis. So to help us to ensure that ensure the post-marketing safety among the JAK inhibitors as compared to biologics in terms of VT risk among older adults with RA. We do acknowledge that there is a need for future study to leverage other data sets, as well as applying other novel machine learning-based survival algorithms, such as neural network deep learning methods, to enhance the prediction performance. Also, at the same time, probably also involving causal forest or causal models to further examine the comparative safety across the BOTS DMARDs in patients with rheumatoid arthritis. So what are my future directions? I would like to continue to advance the application of machine learning pharmacoepidemiology by exploring other real-world data sources to improve the prediction power of these models, thus to better enable the personalized care with a goal to improve patient treatment outcomes. And I just briefly mentioned, I would like to also to leverage causal machine learning models to help to minimize the bias and to obtain a heterogeneous treatment effects among different subgroups to better understand either the comparative effectiveness or comparative safety of these medications. At the same time, I have ongoing research project involving unsupervised machine learning to identify the different phenotypes of particular condition or the medication utilization patterns or comorbidity conditions or even the disease severity among the patient groups to help us to better monitor disease progression, improving outcomes based on heterogeneous subgroup of populations. Now, lastly, I want to move to section 3 to look at, to get to know you better about your interest in machine learning in the realms of real-world research or pharmacoepidemiology. Now, I have a question for you. What is your interest in application machine learning in pharmacoepidemiology or research, real-world research, after hearing me talking about the machine learning project in real-world research? Are you more interested in clinical decision making or personalizing therapy or medication safety, pharmacovigilance, or you're interested in just integrating the machine learning techniques into your clinical practice? Please share one example and provide your thoughts now. This is a time for you just to pause here, and you're welcome to type in the chat box or talk with your neighbors about your interest. Okay. Well, I also want to spend some time just to talk about the potential career opportunities related to using machine learning for real-world research. As many of you, as a future pharmacist, some of you may be interested in industry jobs. If you get a chance to work in those machine learning projects, what kind of stakeholders may be interested in your study findings, and what kind of machine learning application examples that the pharmaceutical company person or people working in pharma may be doing. Okay, so if you are working in a medical affairs team, they may be interested in using machine learning to predict patient-reported outcomes such as fatigue morbidities. You have to tailor your message as to support healthcare professionals or key opinion leaders, as these findings may add evidence beyond randomized clinical trials. Some conference people in the medical fields will go to RD, such as American College of Rheumatology, ASCO, American College of Oncology, or there are also people from drug safety, pharmacovigilance, pharmacoepidemiology teams. They may be interested in using natural language processing-based machine learning to detect new or rare unintended adverse events based on the analysis of physician notes or electronic health records. This study, the findings from the study is to support regulatory submission and speed up the compliance reviews with real-world evidence to ensure the long-term safety effectiveness. And some of the conference are the International Society for Pharmacoepidemiology. If you're working, if you are more economic person, okay, you are more interested in the cost or the economic value, you may be working in a market access team. The goal of this team is to demonstrate the value, reimbursement, coverage, to show the pharmacoeconomic value of your drug as compared to older drug, to help to provide formulary tier and pricing, a negotiation pricing. You may use machine learning to detect disparity in treatment access, affordability, and outcomes across different populations. You want to demonstrate to your payers or health technology bodies that your therapy improves outcome and is also cost effectiveness as compared to an older drug. You will go to American Managed Care Pharmacy Conference or the ISPO conference. Lastly, there is also a commercial branding teams that use the machine learning to predict medication adherence, persistence, help to secure a more targeted marketing and also provide a valued message to secure our patients. Now, I want to thank you for your attention, and you have my email and you know my office, so any question and comments are welcome. And thank you all so much for your attention.